to be here in Massachusetts. I am from North Carolina, so I hope y'all can understand me tonight, because I heard some lovely accents when I was walking around the room earlier, and as a speaker and a coach, I travel all across the U.S. and Canada, so I always love all of the regional dialects. So I hope that you all can understand me tonight, and we're going to have a good program. We have plenty of time for questions and answers, but I do know that we all have lives outside of the dental world, so I'm going to try to be as conscientious of your time as possible. But for those of you that have specific questions as we finish up, I will be here until the last person wants to be here. So please, by all means, I flew all the way up here, so I am at your disposal. I would love to be able to talk with you afterward if you have questions that you might want to kind of dig deeper into some things. So really glad to be here. Now, the topic tonight is, does hygiene have your back? Now, I've talked to a few of you, and some of you are endodontists or other specialists, and you might not have a hygienist per se. But I will tell you, what we're going to talk about tonight will apply to any discipline, because it can be strategies for better open communication with your chairside assistant. It can be better, more effective communication with your admin team at the front desk. It will be back to basics with communication with our patients. So regardless of what discipline you're in, I hope all of you are going to leave with one or two little pearls tonight that you're going to be able to apply to practice tomorrow. So, does hygiene have your back? Now, some of you see this picture and you say, yeah, that looks great. That's not how I feel. I feel like this. I feel like hygiene's got my back, or I won't fill in the blank of what the other God is, but some of you might not feel like your team is quite in sync with you as you would hope. So we do, our business is in consulting and coaching, and so we are Inspired Hygiene. So primarily what we do is we travel across the U.S. and Canada, and we work with doctors and teams who want to get calibrated, who want to either take their Perio program from good to great, or want to start to implement a Perio program. So that is what we do. We also work with clinical team members. We also work with admin teams on better systems in the office. So this is our team. Now, some of you might recognize the brunette woman in the very front row, and that's our president and founder, and her name is Rachel Wall. Just this week, she was selected in the top 25 women in dentistry. So I am very honored to be on her coaching team with her, and we are really proud of the coaching program that we are able to implement in offices all over this country and in all of North America. So I do coaching and consulting. I've been a hygienist for over 20 years. I'm on faculty at the University of North Carolina at Chapel Hill. So I do teach at the dental school. And I love what I do. So the reason I get on a plane every other week is because I love learning from dental professionals like you. And I love for us to be able to come up with some ideas for how you can take your practice from good to great. So one of the things that I want to start with tonight is an activity. Now I know all of you are in the middle of eating, but I think it's important for us to kind of get on the same page with each other. So at your desk, or excuse me, you tell me I'm a teacher, at your desk, on your table, you should see a piece of tissue paper. And there should be a piece of tissue paper for everyone. It's in the middle of the table. It's underneath your salt and pepper shakers. So don't spill the salt, because you know what happens. So go ahead and grab a piece of tissue paper. And if everybody could do this with me, and our wonderful vendors that are here are also going to do this activity. I gave them a sheet as well. So everybody's going to do this activity. Now I'm going to watch you from the front.
There we go.
So if anybody's, cheating or not participating, I will call you out on that. All right. So here's what we're going to do. I'm going to do an activity, and I want you to just follow my directions. You cannot ask questions during the process, which I know is painful for most of us because we're very type A. We want to know exactly what to do. But I want you just to hang tight, and I want you to listen to my instructions. Everyone, please close your eyes, and no cheating. Close your eyes, please. You cannot ask questions. I want you to take your paper and fold it in half. with your eyes closed the entire time. All right, fold it in half again. I'm already hearing giggling, I love it. Fold it in half again.
Slow down.
Fold it in half yet again.
Only get your hands off.
Tear off the right-hand corner. Turn the sheet over and tear off the left-hand corner.
This is a trick.
And once you've done that, stop. Now I want you to open your eyes, unfold your paper, and hold it up so everybody can see. Hold it up, all the way to the back. Now look around the room, and I hope we're getting a picture of this, because this is always a classic picture. Okay, look at the people at your table. Did you have exactly the same pattern with the people at your table? No, you did not. Did you have the same pattern as someone else in the room?
Everybody but me.
Okay, interesting. So here's the feedback.
There's a match.
That's very interesting.
You too.
That's pretty, very symmetrical, like yours. Okay,
Jimmy got like a
very good.
look at that.
I mean, it's a good My eyes were closed.
Now,
I got it.
I want y'all to listen for a second. Hold up. Hold up. I gave you all the same directions, and I have 50 different outcomes. All right, so you can go ahead and you can put your papers down. Thank you for participating, by the way. So, what did that teach you? Anybody want to kind of shout out? What did that teach you?
Different results.
We need better directions. And I heard someone say, and there was a gentleman over here, when I was barking my orders, slow down.
That would be me.
It's all right. You know the reason I do it at that pace is because I'm supposed to push you. I'm supposed to make you feel frustrated because, folks, that's how your team feels often. I heard that. I've got mom ears. I heard that. So that's how your team feels often.
Good to be king.
And team members that are here, that's how your doctor feels often. So this is a really good exercise that I like to do when I'm either speaking in groups or in offices, because I think so many times we think we give really bang-up instructions to our team, and darn it, why aren't they doing what I've asked them to do time and time and time again? Or the team is thinking, well, gosh, you know, we've talked about this multiple times, and I thought we were really specific in our new protocol. Why is doctor undermining us? I thought we agreed we were going to do it this way. So the bottom line is, in our experience in working with teams, rarely are there ill intentions. Most of the time, it's a lack of communication that's specific, that everybody understands. So that's one of the concepts that we're going to talk about tonight, so thank you for playing along. So as you look at this slide, this section of the program is really focused on hygiene and hygiene production. So I heard earlier, you know, I'm mad as hell and I'm not going to take it anymore, and one of the things that was mentioned was, you know, your hygienist isn't producing and you don't know what to do about it. So many times we see some benchmarks in practices that really need to be established and agreed upon and very clearly defined and documented so that the team knows exactly what's expected of them and so that they know where they're going. It's like if I said, Gretchen, I'm going to give you a pair of running shoes and I want you to strap them on, I want you to go run, and I don't want you to stop running until I give you the timeout sign. So get going. So she goes out and she starts running. And she's 2 minutes into it and she's thinking, man, I'm in shape, I feel good. And 20 minutes into it, she's thinking, this ain't too bad. I'm in shape. 2.5 miles into it, she's thinking, okay, how much longer is this going to last? 2 hours into it, she's thinking, this is awful. This woman is breaking me down. I'm working and running as fast as I can. When is this going to be over? So doctors, many times, if we aren't transparent with our teams on certain benchmarks, they feel like they're working as hard as they can, but it's never good enough. It's never good enough because we're not transparent with our expectations. So I'd like to run through some benchmarks just quickly so that we all are on the same page, and then we can discuss after if some of you have specific questions on these benchmarks. Now, have you ever looked at hygiene production and heard this equation before? So hygienists need to produce blank times their salary and benefits. Have you ever heard this equation before? Hygienists, raise your hand if you've ever heard this equation before. Okay, this is not abnormal. Very few of them do. Now, we didn't take a class when we were in hygiene school to understand the business side of dentistry. I teach at a dental school. I also know that as doctors, you don't get the business side of dentistry. This is something that you learn along the way. So, hygienists don't feel bad if you don't understand what these numbers mean, and I'll tell you in a minute to kind of put it in a frame of reference why we need to talk about production, because it really allows for us to practice more comprehensively. So let's take a look at the equation. Hygiene needs to produce, anybody want to guess? 3 times salary plus benefits. Now, if a hygienist is sitting there, and let's just use a number that's easy to work with, because we were talking earlier, one of the reasons I went to hygiene school is I'm not the world's biggest fan of math. So I will use a number. The doctor never shared with them these basic numbers. So believe me, when we sat down and went over this, I mean, there were tears in the eyes of the hygienist because they felt so awful, that they felt so angry that they hadn't received the raise that they thought they deserved. So there are a lot of factors for why this happens, and we'll talk about them a little bit tonight, and we can stay after and I'll chat with you a little bit more about that. So 3 times salary plus benefits. That's just so that your doctor is not running in the red. Open time. Do you have a benchmark in your practice for what you consider to be your benchmark of open time? Open time means there's a last-minute cancel or a no-show, or the appointment was never scheduled. How many of you, raise your hand, have a benchmark of what you consider to be appropriate, acceptable open time? Raise your hands.
0.
Okay. Just a note for the room, no hands went up. Okay. It's okay, but here's the benchmark I will give you, is that if you run the numbers and you take a look at your open time, there's always going to be somebody that has a flat tire. There's always going to be a patient that, they woke up and they have strep throat. So that stuff happens. So we consider the open time benchmark of 8 to 10%. So you simply take a look at your book for the month. You count how many available openings there were, how many appointments were available in hygiene. So if you have 2 hygienists and they see X number of patients per day, and you run the numbers for the month, and then you count up how many unscheduled appointments or no-shows or last-minute cancellations, and that's how you're going to calculate your open time. Part of the problem with that office in Indianapolis is they had raging open time. So the raging open time deals with confirmation protocol and procedures, what kind of software system they're using to confirm. I started 20-some years ago where you called them up the day before and said, this is Linda at Dr. Pachowski's office. I'm just calling to remind you of your appointment. Beep, and you left a message on their home phone, answering machine. That's what we did. Well, we know that no longer is the appropriate way to contact busy patients with lives that are going in 100 directions. So this is your benchmark, 8 to 10%. Higher than that, and you will see your hygiene production just absolutely dip down and they will not be profitable. What percent of doctors' monthly production is a direct result of what gets treatment planned in hygiene? You know, that quick hygiene check that you do to go check your hygiene patients. Doctors, it's critical. What percentage of what you see in your operatory is a direct result of what got scheduled out of a hygiene check?
85.
Okay, you guys are shooting for the stars. So 60%. So still, when you think about that, if we don't have systems in place for when we come in to do a hygiene check, and doctors, you're always running in at 5 to the hour with your hair on fire because you have 2 hygienists that need checks, it's really hard for you and the hygienist to have a perfect handoff. And we teach really sequential systems for how you do that handoff. And one of the things that we coach is do not wait until 5 to the hour to come in and check at the last minute. It's very difficult for you to be able to do what you need to do and co-diagnose with your hygienist. And it's important because that is the bulk of your production, is what you and the hygienist are co-diagnosing out of the hygiene check. Your Perio percentage. So in your practice management software, EagleSoft, Dentrix, OpenDental, whatever you use, your admin team will be able to run for you your production by procedure reports. So you'll hear from your hygienist, oh my gosh, we do a lot of perio, or gosh, we do a lot of scaling and root planing. It's good to know what's fact, and you know, we want to make sure that we're reality-based and we're fact-based. So have your front office person do this for you, run the numbers, and they're going to be able to figure your perio percentage. And I'll share with you in just a second a free online tool that you can have your office manager plug your numbers in so that you're able to get a really clear perio percentage. So in a second we're going to talk about, well, what do the statistics tell us as far as perio percentage, as far as the incidence in the US. But what we see is if a practice gets to 25% perio, that's solid. Now, we're going to talk about incidence in a minute, and I think you're going to argue with me that that number is actually too low, so we'll get to that in just a moment. So, hygiene. When you look at doctor production and hygiene production, what percentage of overall office production should be coming out of hygiene? Anybody ever had you explain to you that number, or any of you have a guess? What percent of overall production? So, it's important to know this. Third, very good. So a third of overall production should be coming out of hygiene. I worked with a doctor in upstate New York. Hygiene was 49% of overall office production. Why do you think that is? How did hygiene become 49% of overall office production?
Doctor's lazy. The doctor's not producing.
Okay.
A lot of golf.
Okay. So we can all speculate. You know, the first comment was, lazy or golf. It's hard to say. Many times it's because, and in this practice, they were doing an accelerated hygiene schedule where the hygienist was never in the room when doctor came in to do the checks. So there was not an ability for them to do co-diagnosis. So the hygienist was seeing double the amount of patients, but her production was still low. And then doctor came in at 5 to the hour with his hair on fire and tried to do this big comprehensive exam and see everything and then dash out and go see his patient in his room. So we slowed everything down to a straight schedule and had a sequence for how doctor and hygienist would co-diagnose and hand off, and doctor's production went up and hygienist production went up, seeing half the amount of patients. So I'm not saying that assisted hygiene or accelerated hygiene is a bad thing. It's not, but you have to have a really strong system in place for how that goes, because hygiene producing 33% of overall production is a good barometer of how well balanced. Sometimes, you're right, sometimes when we see, hygiene almost 50%, that's what we call a Timex practice. You know what that means? Because doctors watching everything. Watch. It's a Timex practice. So sometimes it's doctor not really embracing his or her own diagnostic skills and being able to have the conversation with the patient to explain more comprehensive treatment that's needed for the patient. So interesting equation, and I encourage you all to run your numbers on that. The service mix. You will never, as a practice, be able to break into the first level of profitability if you're doing Profi exam bite wings. We're going to talk about diagnosing perio in just a second. I'm really glad that you're in the room tonight because I think you'll be able to share with us some insights. But we'll talk about just looking at what does the AAP say is disease and what is health, and what do those darn CDT codes actually say is disease and health. Because what's happened over time is we've sort of used the prophy as the catch-all. So when you run the numbers, you'll see that most practices are prophy heavy, because we have kind of lost sight of, well, what is the parameter for health and disease, and what is the appropriate use of the CDT code of the 1110, the 4910, the 4341, the 4342, and so on. So if any of you want to take a picture of that slide, come up afterward. I love technology. I love it. CE courses now, everybody has their iPad and they're taking pictures of my slides. Go for it. I think that's great, and I'll be happy to share this slide with you. If you want to take it back to your office manager, I can email that to you so that you have that for a frame of reference. So when we talk about Perio Protocol or Perio programs, now I know we have some folks in here that aren't, you don't have hygienists, you don't have a Perio program per se, but I want you to take a second, and I want you to work with your table, and I want you just to spend 2 minutes, not talking about, the Patriots or anything, talking about what we're talking about here. I want you to identify, just with the people at your table, what are you most satisfied with your Perio program right now, and what are you least satisfied about? And I'm going to give you 2 minutes to do it, so go ahead and chat with your table, and I'm going to time you.
When you go, without him, I go through it. I'm a top. Our Perio treatment is is 1, 2, 3, 4, 5 quadrants a month. It's 9. I look at it. I go, it's like you do trophies.
So are you satisfied? You think the amount is appropriate? No, but you think the amount is appropriate? In other words, you're saying
it seems to be, but I'm curious why our Perio program is not existing. Beyond, we have 3 agendas in 6 days. No, 1 full time, 2.
What criteria? All right, Trace. What criteria do you use? Let's say in his office, when a patient needs
Group playing and scaling.
Well, every patient we do Perio charting on, there's different comprehensive plan, we set that frame, and then from there we just gather all the information.
60 more seconds.
We get that writing on there, leading upon probing, put all that information together.
All right, let's say no bone loss. Let's say no bone loss, no mobility, tissue's puffy, bleeds easily. Every time they come in, it's a bloody cleaner. But they don't meet the 5 millimeter pocket criteria.
What, scaling?
Alright, so let's stop for just a second.
Doing something
And the reason I give you a short amount of time is that you should still have more to converse about, which is why we have association meetings like this, so that we can continue the conversation. Who wants to share? What are you most satisfied about with your current Perio program? Who wants to share? Anybody? First person to share. There might be something in it for you. Go for it.
Well, we now have a periodontist coming into our office 2 afternoons a month. And I think that has made a difference. More people are willing to see the periodontist because he's part of our practice, rather than have to leave our office to go. So I think that's made a difference for all of us.
All right, do you feel like having sort of Perio top of mind, because you have a periodontist in your office 2 days a week, do you feel like it has increased the level of awareness and maybe the Perio conversation is occurring with more patients? Absolutely. Okay, there's a $25 Starbucks card for being my first person, so there you go. It behooves you to participate.
I knew there was a prize.
All right, enjoy your coffee. Okay, I've been coming in every 6 months, and you always tell me, get on that flossing, and it seems like it's normal for my gums to bleed. Why is today different? Yeah, so when a patient says, yeah, but I've always been able to get my teeth clean, we always answer a patient when they are legitimately giving us a little pushback to say, you're right. You're right, Mary. We have talked about that bleeding before. You're right, Mary. We have discussed this before, but we now know through current research that this type of inflammation means so much more than what we thought even 6 months ago. And one of the things I love about working with Dr. Smith is Dr. Smith always tries to take a conservative approach first. And that's what we've been trying to do, Mary. But that conservative approach is no longer working. And that is a way that we can have a very, I'm going to use the term authentic conversation. It doesn't sound like we're trying to sell them into scaling and root planing, because that feels gross for all of us. It's not ethical. That's not how we, that's just not our standard. But it's a very legitimate way for us to be able to discuss with the patient. You're right. We have talked about this in the past, but we now know. Guys, the patient doesn't need to know that we've known for 6 years about, X, Y, and Z with oral and systemic and inflammation. And, truly, we've decided that as a practice, we're going to draw a line in the sand today, and today we're moving forward. We're not going to hang out where we practiced 6 months ago, 6 years ago. We're going to move things forward. So thank you, Heather, for sharing that. So who wants to dish? What's the least satisfied? What are you least satisfied about your Perio Protocol or program right now? Come on, somebody. There must be something. It could be something small. Yes, sir.
It's almost non-existent.
Almost non-existent. Okay. So you are, thank you for being brave, because I bet there are about 19 other people that are sitting here thinking, I wanted to say the same thing. It takes a lot of courage to say that. So it's almost non-existent. So one of the things that can
He likes coffee a lot, by the way.
I'll see if I can pull out any kind of gift for you. I'll work something out for you. So when we say, it's almost non-existent, you're not alone. So let's take a step back and let's talk about the epidemiology of it all. We were talking about public health and statistics beforehand, so y'all are going to love this conversation. But when you have patients and you're going to talk to your patient about perio, we run around and we talk about different percentages. What is your typical line when you talk to patients about perio and they say, oh my goodness, I didn't know I had gum disease? And you say, well, Bill, it's very common. X% of the U.S. population has some form of periodontal disease. Tell me your percentages that you're typically quoting to patients. There's no wrong answer, by the way. What do you typically say?
95%.
Sorry?
95.
95. So 95%. Okay, what? That's one number. What else?
25 to 40.
25 to 40?
35.
35 to 40. So 35 to 40%. Okay? So here's the thing. It's interesting, if you look at AAP or the ADA, or you look at the Centers for Disease Control and Prevention, everybody kind of has their own take on the numbers. So if we say the majority of patients, let's just say the majority of patients, and you look at those numbers, and they range from 40% up to 80% of the population. And then I want you to take a look at the percentage of patients in recare. Again, it goes back to running the numbers. Knowledge is power, and assuming things about your practice gets you in trouble. When you assume your overhead is this, that's probably not good enough. You have to know what your overhead is. So assuming that you think, well, probably about a third of our patients are in periotherapy or in maintenance, run the numbers so you know. So if you think about this, I'm going to ask the hygienist quickly. So for the hygienist, Heather, you guys are out of this conversation, so, hold on, sister, I'll get back to you in a moment. For most of the hygienists in the room, what percentage of patients in recare would you say have at least early perio? So we're talking, it's a 4, it bleeds, but there's radiographic evidence of bone loss. Because just because it's a 4 doesn't mean it's a 4, it could be a pseudo pocket. So what if we said it's a 4 that bleeds with at least early loss of crestal bone? What percentage of patients that you see, hygienists in recare, fit that description? Don't be shy.
Close to all.
Okay, I heard almost all of them. That's a comment I hear a lot. Okay, well, let's just be super conservative. What if it was half? What if it was half of the patients in recare? Think about that when you run your numbers. Doctors, how many of you see new patients first? Raise your hands, please. You see new patients first. Okay, so doctors, think about the new patients you saw this month. You're seeing what, 40, 50 new patients a month? We can help you with that, by the way. So let's say you're seeing 20 new patients a month. So doctors, what percentage of those new patients, I just described what we consider to be early perio? 4 with at least early loss of crestal bone visible on the radiographs and bleeding. What What percentage of patients are you seeing as new patients that fit that bill? What would you say?
Most.
Most. So 80%, and I heard most. Okay, right. So here is a free online tool. Write this website down. This is a free online tool we offer to all of you. If you go to inspiredhygiene.com/Perio tool, all you have to do is have your office manager run your production by procedure report. Have them run it September 1st, 2012 through September 1st, 2013. And when he or she runs that for you, they're going to plug this number in. When you download it onto your computer, it's an Excel spreadsheet, so it's pretty easy peasy to plunk in the numbers. And when you put those numbers in, it's going to spit out what your perio percentage is. Because many times what will happen is you'll think, you know, we're doing a good number of scaling and root planing. So this is, for example, one of the offices that I've worked with, and they say, man, we did over 200 SRPs. Yeah, but then when you add in perio maintenance, and then you look at the numbers of patients that you see in prophy, it shakes out that you're doing 14%. Now, folks, we see practices where it's 1% or it's 2%. Not uncommon, but hey, you only have up to go from there. I mean, that's a way to really get the foundation laid. What you have to decide is, you know, what's going to be appropriate for us for our goal. Again, like I said with Gretchen, if I said just go run, I mean, that's frustrating. Go run how long, and this is how much time it's going to take you to do that. I want you to do a mile in at least 9.5 minutes. So now she knows exactly what she needs to do. So please download that. It is free from us to you. It's a great resource. Share it with your team. Email me with questions that you have about that. And again, I'll put that slide back up at the end. You can kind of run up here with your smartphone and you can zap a picture of it, or I can email you the link directly. So here are 4 common, now there are many, but these are 4 common roadblocks that we see when we do an analysis of an office and their perio percentage is not where they want it to be. The 4 common roadblocks that we see are listed here. Number 1, not collecting enough data to make a diagnosis. So you have hygienists, I've seen this many times, you have hygienists that are so jammed on time because they're doing quasi-scaling and root planing on prophy patients. So they're so jammed on time, they're doing the best they can, so when push comes to shove, not everything fits in. So what they end up doing is spot probing. Or there's no protocol in place in the practice. So, you know, doctors, you really, it behooves you to sit down and say, all right, on our recare patients, we're going to write it out. What's our standard of care going to be? Not talk about it. We're going to write it out as a team. Because if you talk about it, here's what's going to happen. 3 months later, you're going to walk in to do a hygiene check, and by golly, the perio chart's not done. And you're going to be fuming mad. Well, talking about it's one thing, but sitting down, using production time, and I know that's kind of using production time to say, all right, guys, let's map it out. What's our standard of care going to be? How often are we going to perio chart? On which patients? What data needs to be collected? Doctor, you might be fine with 6-point probing and bleeding sites. Great. Write it down, and everybody agrees to that. Or you might want more data collected. But you can't, as a doctor, make a diagnosis if you don't have all the data present. So that's one of the roadblocks we see to doctors feeling like, you know, I know there's all this perio in my office, but it doesn't show up in the numbers. So having enough time to do that. Looking at how much time you give your hygienists. I will say this, that if you have less than 50 minutes, I've done this for 20 years. If you have 50 minutes or less, it is near impossible to collect the data, not only so that you, from a liability standpoint, are protected for documenting disease so you can make a clinical diagnosis, but it absolutely hinders and hamstrings your ability to have your hygienist be your co-diagnostician. Now, I know in the Practice Act, you know, hygienists aren't to diagnose, but I will tell you, in the most successful practices across the globe, when doctors have sat down with their team and said, let's look at x-rays, tell me about the bone, what do you see here? This is what I call a crown, this is why I don't call it a crown, look at this, look how much of the cusp is involved, that's why when I come in, that's why I'm going to talk to the patient about a crown. No, we don't want our hygienist telling the patient they need a crown if you haven't calibrated them to that. That can really get the practice in trouble. So really making sure we're clear on what diagnostic information needs to be collected, critical. And if you have less than 50 minutes, it's really tough. And if you see your production doctors, you're not hitting your production goal every month, sometimes that's one of the reasons why. Number 2 is not being calibrated. On faculty, every year we go through clinical calibration. So we all sit down, we bring in these poor patients, and we all probe these patients so that all the faculty are calibrated. I do this when I go in and coach teams. We bring in a patient, and we sit down, and we all probe doctors too, because for you to see new patients, it's important for you to be calibrated. So we sit down and we work on things like technique, being able to read. I wear loops. I've worn loops for probably 6 years. And one of the things that I'll notice is when there's a lack of calibration, if the doctor says, man, you know, I'm always getting deeper measurements than Sally, many times it's because Sally is of our age group where, you know, vision starts to become an issue. So wearing magnification, real simple things like that, but getting calibrated on probing technique, getting calibrated on how you read radiographs, getting calibrated on all of the systems and diagnostic tools that you use, doctors, not so that your hygienist can be the mini-me dentist, it's so that he or she can help support you better, so that essentially when you walk into the room to do a hygiene check, I want you to envision the bobblehead doll that you get when you go to the baseball.